Whose birthday I just missed?
मीरा मैम
का बर्थडे।
संचिता has been trying to call
हमारी
you.
पैट्रन, हमारी हीरो।
बताइए मैम।
My
Dr. Sanchita
mentor.
has been trying to call you. Prerna this side.
Okay, okay.
Meera ma'am.
Yeah, I am very much here.
Sanchita has been trying to call
Thank you, everybody.
No. We will start now. Dr. Kiran Kurtukudi sir will join in few minutes.
पंकज,
अरे यार ये क्या हुआ?
मैम आप दिख रहे हैं, आप दिख रहे हैं, यू आर ऑडिबल।
कोई नहीं दिख रहा ना, मुझे ये तकलीफ हो गई है।
देखो ये कैसा मिलेगा, उसका रीमा बोला जाए।
आप मोबाइल पे है ना मैम, एक बार
हाँ,
स्वाइप स्क्रीन स्वाइप कीजिए एक बार।
लैपटॉप पे पता नहीं ज्वाइन क्यों नहीं हो रहा। मैं देखती हूँ थोड़ा सा। नीचे करो, ऊपर।
Okay, sir. Now we are live on YouTube. Madan sir?
ओके,
Yes.
प्रेरणा जरा ध्यान रखना, अपने किरण सर ज्वाइन कब होते हैं।
Yes, yes.
Khadija.
Yeah, okay. Good evening, everyone. On behalf of AMOGS Sexual Medicine Committee, I'm very delighted to invite you, welcome you all for this special webinar organized by AMOGS with Uttar Pradesh Obs and Gynae Societies. Actually, this is the second episode with Uttar Pradesh Societies. Just last Thursday, we had first 15 societies of UP with AMOGS, and this is the second episode covering the rest of the 15 societies. And we are very happy to connect with UP societies. We called each and every president and secretary of society, and everyone responded very well with happiness and love. And we are very much happy to have you all. With the blessings of AMOGS office bearers, President AMOGS, Dr. Kiran Kurtkoti sir, Bipin Pandit sir, who is the honorary secretary AMOGS, and I welcome today's chief guest, respected Padma Shri Professor Dr. Usha Sharma ma'am. Everyone knows ma'am very well. Also, I take this privilege to welcome all the guests of honor for this particular webinar. Our own President AMOGS, Dr. Kiran Kurtukoti sir, Dr. Narendra Malhotra sir, who is the past President POXI, Dr. Preeti Kumar, Vice President POXI North Zone, Professor Dr. Meera Agnihotri ma'am, and Dr. Chandravati ma'am, with the past Vice President POXI. We welcome you all, and I welcome my co-convener, Dr. Prerna, and Dr. Apurv Datta also. We are having two talks today and one panel. I welcome all the speakers. Today's speaker is Dr. Apurv Datta and Dr. Sanchita Dubey from Noida Society. And I welcome all the chairpersons of both the sessions. And the panel is on psychosexual crisis in midlife. I welcome all the panelists and experts for this session. I welcome all the delegates who have joined from all the societies of Maharashtra and Uttar Pradesh. So, Harshvardhan, can I have the CV of ma'am?
Yes, sir. Just a second.
Yeah.
Sir, is my screen visible?
Yes, yes. Please have CV of Usha ma'am.
Okay, just a second.
Yeah, ma'am is the senior most gynecologist and Padma Shri awardee, and ma'am was lifetime chief patron of UP chapter of Obs and Gynae and patron of Mirath OBGY Society also. Ma'am has been an outstanding student in UG and PG curriculum in all subjects, and she was awarded President's Best Medal, President's Medal for the Best Medical Girl of India. And most important is she was awarded Padma Shri in 1985. she had done a tremendous work in the field of laparoscopy, and recognizing that work, she has been awarded a laparoscope by late Prime Minister Mrs. Indira Gandhi, and also she has achieved lot of achievements and lot of awards. Such a huge list is
I
there.
think Dr. Kamble, it's
Yeah.
okay.
या दो तीन तो बताता हूँ मैम. इंदिरा गांधी प्रियदर्शनी अवार्ड है, महिला रत्न है, मीरत रत्न, हरि ओम, बीसी रॉय, बहुत सारे हैं मैम. वी आर वेरी हैप्पी एंड डिलाइटेड टू हैव यू here, and we want to listen you and have your blessings. Over to you, ma'am.
Okay. Thank you very much, Dr. Madan Kamble. It's really a great pleasure for me to be with you all today on the occasion of AMOGS, AMOGS Sexual Medicine Committee webinar on sexuality as well as various subjects on sexuality, and along with the Obstetric and Gynec Societies of Uttar Pradesh. We have got today with us Dr. Kiran Kurtukoti, who is the president of AMOGS, and Dr. Vipin Pandit, who is the secretary. And with us, we are having Dr. Madan Kamble, Dr. Prerna, and Dr. Apurv Datta. And it's really a very, very important subject. We all know that sex and sexuality are the terms which usually we do not speak about that or do not discuss about that in public. Indian females' attitude is they are usually very, very disinterested also in sexual functions. And this many times creates great problems in the family, as well as this gives to very psychosexual impact also on the marital status. And even we, the clinicians, when we just talk to the patients, we talk more about the antenatal care, more about the natal care, as well as the postnatal care. But we do not give any importance to this sexes because probably we are also not very much clear about the doubts of sexuality in pregnancy. And especially in the era when each and every pregnancy is a very precious pregnancy, as a very high risk pregnancy. A lady undergoes different transition phases during her reproductive age group because there is, first of all, there is a reproductive period when she is pregnant, she is lactating, and then comes the midlife. And in this midlife, because there is decrease in estrogen, progesterone, and androgen. So there are many problems like genitourinary syndrome, and this includes the pre-menopausal as well as the menopause period. And so it is very, very important for every one of us to know each and everything about the sexuality in pregnancy and other subjects. And I am very happy that today we are having three talks. First is the sexuality in pregnancy, where we have got Apurv Datta who will be talking to us, and then we have got the another one is genitourinary syndrome and menopause, as well as then we have psychosexual crisis in midlife. And I will also like to welcome the guest of honors, Dr. Kiran Kurtukoti, Dr. Narendra Malhotra, Dr. Preeti Kumar, and my very dear Dr. Meera Agnihotri. She is also patron of UPCOG, and Dr. Chandravati. And I'm sure that the deliberation today will go a long way and everyone will be greatly benefited by this. The thing is that till we are also well aware, because we have got so many doubts about this sexuality. Even I tell you, Dr. Madan, that many times I also feel that few things even we clinicians do not know. And that is why even if you take a decade back, actually nobody was so much interested in sexual medicine and sexual health. And so I am very grateful to Dr. Madan Kamble, Dr. Apurv Datta, and Dr. Kiran Kurtukoti, Dr. Vipin Pandit, to associate and collaborate all the obstetric or most of the obstetric gynec society of UP and dealing with this subject, which is really very, very important, though it is not discussed much, but it is a very important subject. And I congratulate you for organizing this, and I am sure that everybody will be greatly benefited with this. Wish this program a great success, and thank you very much for making me a part of such a prestigious event. Thank you.
Thank you so much, ma'am, for your kind words and blessings. Actually, the Foxy Sexual Health Committee and every sexual health committee of, for example, AMOGS and all, they are working so hard to create the awareness about the sexual health. That is because that is the need of our, and first aim is to create the awareness amongst our fraternity only, our gynecs only. Then and then we can serve the people. Yes, thank you so much, ma'am. Yeah, Harshvardhan, next slide.
Thank you, Usha ma'am. That was indeed hearing from you is a treasure. And you are a pathfinder of many of us Foxians, ma'am. And you are a steer leader of excellence, as we have seen in your CV, ma'am. That is something beyond compare. And you are so beloved and still so grounded. And that makes you so, so very loving. And we are so very honored to have you amongst us, ma'am, today. And you are, you have achieved such realm of achievement, and that you have set apart was something which is beyond any comparison. Thank you, ma'am, for being with us. Thank you, ma'am. Thank you, Usha,
Yes.
ma'am, for your kind words.
Yes, next
Uh,
slide.
We have our next, Kiran sir has not joined, Dr. Madan.
Yes, sir. She will join later. Yeah, next slide.
We can introduce Meera, ma'am.
Yes, yes.
Meera, ma'am.
Malhotra sir is not joined yet. Next slide. Yes, Preeti Kumar ma'am is also in traveling. She will not join. Yes, you can introduce Meera ma'am. Prerna.
Uh, Meera ma'am, what to say about ma'am? Ma'am has been the pioneer, a visionary, and she has been so reputed in all OBGYN organizations across the globe now. So ma'am is so very beloved, ma'am. As a Foxian, ma'am, we look up to you for so many unabated dedication and your exemplary leadership over years now,
Thank
ma'am.
you,
Ma'am,
beta. Thank you very much for the lovely kind words. I am a family member of all the persons present over there. So they know more than I know about me and you. So need not to be. I'm very grateful to the Sexual Medicine Committee for making me a part of this great meeting and sharing the dais with our beloved Usha ji, Kiran, Narendra, Preeti, and Professor Chandravati. It's always an honor to be with them. You always learn something from your friends and add to it knowledge. I can, at the outset, tell you that I was first chairperson of the AIDS committee, AIDS committee, in our Foxy. And that was years back, that maybe somewhere near 76 or at that time, sexual committee was not made. And I can tell you, I represented India in Texas for this thing because all these sex talks were supposed to be under the carpet whenever they were being talked. So they will talk everything, your old mothers, your girls. I mean, a girl has become pregnant, but she doesn't know about the sexuality. She's unmarried, she has become pregnant. A 10-year-old girl has become pregnant. The patient has become HIV positive, doesn't know. So at that time was the beginning of the situation. I'm very happy that the Sexual Medicine Committee is especially made for this purpose, and it is the need of the hour and demand of the time. Why? In all spheres of the life, whether it is education, treatment, or anything, you can take off this vaccination of the cancer cervix. It should be given to both male and female. But as we start talking about the sexuality being involved in it, our target population will be just under the carpet and we will not be able to deal it. So this is a very important subject. I am very thankful that you have chosen this subject in different phases of the life, uh, especially sexuality in pregnancy. Very less talked about, very less discussed, very well published, even not much literature will be available. And the second one, the genitourinary syndrome in the menopause. Yes, we are all aware about it, but during pregnancy, you should be talking about. I am very happy that you have kept a panel discussion on this sexual crisis in midlife. So these are the three subjects. We started with AIDS very beginning in our Foxy, and I am very grateful that the Sexual Medicine Committee has been made. And I personally feel that in all walks of life, be it obstetrics, be it gynecology, or any part, it has to be discussed. It should be discussed. Rather, it should be a NB for every chapter. Thank you very much for making me a part of this great meeting. I love to be there for some time, and I congratulate the organizers for giving me opportunity for being with you today. Thank you very much. Thank you
Thank
very
you,
much.
ma'am. Thank you. Thank you so much. And once again, a very,
UP
very
is
happy
always
birthday.
with you. Sexual committee, I can, on behalf of UP, on behalf of Usha ji, on behalf of Preeti and Chandra ji, everybody, I can commit that we are all with you wherever you want us. Thank you very much.
Thank you so much, ma'am. Thank you
Ma'am.
so much.
Thank you for all the wonderful words. And, ma'am, what a foundation that you have laid as a founder chair of STD and AIDS committee. And we look forward towards carrying the baton. And, ma'am, this is really, really very dedicated efforts of yours that we have reached such a realm today in sexual health and medicine, speaking about it from under the carpet to public speaking and all aspects of sexuality. Thank you, ma'am, for that vision way back in 1976. So, and once again, a very, very happy birthday to you, ma'am. And we are glad
Thank
that we could have
you.
connected on this very auspicious day with you, ma'am.
Very
Uh,
true.
we- so we have, we can start our scientific sessions if more of
No,
our
no.
guests
Before
of
start,
honor.
we would like to have e-lamp lighting. Harshvardhan,
Okay.
please, can I have the slide? I invite all the dignitaries to
Sir,
join
should I
e-lamp.
start?
Yeah, yeah.
Yeah, okay.
Thank you. I also welcome Dr. Bharti Maheshwari ma'am, who is traveling, but she has joined. Welcome, Bharti ma'am. Okay. So we will move forward to the scientific session. Once again, thank you so much, all
Yeah,
the
hello.
guests. Yes, ma'am.
Madan, so congratulations for such an informative webinar. And I am keen to listen all your important topics. Then I will join for expert comments after the talks. Thank you.
Yes. Thank you so much, ma'am. Thank you. Harshvardhan,
Yes, sir.
can I have the slide of first session now?
Okay, sir. Okay, so should I start?
Yes, yes.
Okay, so first of all, very, very good evening, respected faculties and delegates present over here. On the behalf of Corona Remedies Private Limited, I, Harshvardhan Uday Kumar Nalaude, welcome you all to the Core Connect live webinar in association with the AMOGS Sexual Medicine Committee with UP OBS and Gynae Society. So starting off with our conveners, we have panel of three. Basically, we have Madan sir, Prerna ma'am, as well as Apurna sir. So talking about Madan sir, he is chairperson of AMOG Sexual Medicine Committee and also Foxy Sexual Health and STI Committee. Talking about Prerna ma'am is a national and international level publication journalist. Basically, she has a lot of awards. first of starting
Harshvardhan,
off with.
Harshvardhan, I'm just the national coordinator for Young Talent Promotion Committee, Foxy. That will be enough.
Yes, ma'am. Yes, ma'am. Yes. So he's his own leader for YTPSI, Foxy, Yuva coordinator for Foxy.
That's
And
enough,
yes.
Harshvardhan.
Okay, ma'am. Then we have Apur Kumar sir. Apur Kumar sir is National Coordinator for Public Awareness for Foxy Sexual Medicine Committee. He is Regional Faculty and Master Trainer of SADH, as well as he is winner of RD Pandit Research Award 2021.
I
Now,
think this is
live.
a
Yeah,
old.
yeah. He is the chairperson of
He is
Foxy
the
Sexual Health
chairperson.
Committee.
This is the
Yes.
old.
Whole slide.
CV.
It's okay.
So now I would like to hand over the session to Madan sir.
Okay. Yes. Yeah. Before starting the session, myself and Dr. Prerna would like to appeal all the presidents and secretaries and all the seniors in the Foxy to kindly support and vote for us for the upcoming elections of Foxy chairperson. I'm going for Sexual Health Committee and Prerna is going for YTP Committee of Foxy. We need your blessings. Thank you so much.
All the best. All the best.
Thank you, ma'am.
Thank you. Thank you.
All the
Can I have
best,
the next
Dr.
slide?
Madan.
Yes,
Yeah,
thank
all
you.
the best.
Harshav, the next slide.
Yes.
For the session. Yeah, we are starting the first session. For this session, we have got the eminent speaker, Dr. Apur Kumar Datta, and the chairperson for this are the Dr. Bharti Maheshwari ma'am. Can I have the CV? Dr. Seema Mehrotra ma'am, Dr. Kanchan Sharma ma'am, Dr. Shweta Sharma Kaushik, and Dr. Ritu Khanna ma'am. Yeah, open the CVs. Dr. Bharti Maheshwari ma'am is the Kanchan Sharma ma'am is the Foxy chairperson for NCD committee. Welcome, ma'am. Next.
Thank you,
Next
Dr.
slide.
Madan and Prerna. Best wishes on my behalf.
Thank you.
And
Thank
thanks
you.
for making me a part.
Yeah. Bharti ma'am is the Foxy ICUG Governing Council member, president of Meerut OBGY Society, and founder president of Meerut ISOPAV, and also Menopause Society. Welcome, Dr. Bharti ma'am. Next.
Thank you, Dr. Ramadan.
Yes. Yeah. Ritu Khanna ma'am is the director of Khanna Medical Center, and she's the past Foxy chairperson. Welcome you, ma'am. Next.
Thank you.
Yeah, Dr. Seema Mehrotra, ma'am is the professor, Department of OBGY, KGMU Lucknow, and currently the secretary of Lucknow Obs and Gynae Society.
Thank you, Dr. Madan, for making me part of this webinar, and all the very best for your elections to you and
welcome,
Dr.
ma'am. Thank you so much.
Thank you.
Next.
Thank you.
Yeah, Dr. Shweta Sharma Kaushik is the consultant Obs and Gynecologist from Sri Sai Hospital, Moradabad. Yeah, she is my classmate from Solapur. I welcome her.
Thank you, Dr. Madan. Because of you, I could see so many of my seniors and friends. Hello, Seema ji.
Hello, Shweta. Hello.
Yeah. I request Dr. Shweta Sharma Kaushik to introduce our speaker, Dr. Apur Kumar Datta. Yeah. Over to you, Dr. Shweta.
Kindly join with the CV.
Yes.
So today, he doesn't need any formal introduction, though his introduction is he is the chairperson of Foxy Sexual Health and STI Committee. He is National Coordinator for Foxy CME and Workshop for Safe Abortion and Contraceptive Cafe 2020.
Thank you so much, ma'am. Thank you so much for your
He is the
kind
National
introduction.
Coordinator of Public Awareness for Foxy Sexual Medicine Medical Committee, Regional Faculty and Master Trainer for TOT SATH Foxy IAP Initiative. He is the Executive Founder Member of Jharkhand State Chapter of International Spina Bifida Foundation, winner of RD Pandit Research Award, winner of Champion of Foxy Award 2021, winner of Kamini Rao Yuva Orator 2020, winner of National IMA Community Service Award. So he has got so many awards in his account.
Thank
And
you,
he is the
Shweta. Being chairperson, I just want to say only 2 lines about the Apurva. First of all, my regards to my patrons, Dr. Usha Sharma and Dr. Meera Agnihotri madam, and all the seniors. Apurva Datta is one of the very active, eminent, youngest, and very enthusiastic chairperson, which I found in amongst us. He is
Thank you
very
so
actively
much, ma'am.
participating in all the activities and always very, very cheerful. This is I think enough introduction for him.
Yes, rightly
I'm
said, ma'am.
So we
always
Rightly.
all
welcoming
welcome
Thank
him.
you.
Dr.
Thank you so
Apurva
much, ma'am.
Datta.
So kind of you. And me and Kanchan ma'am started our journey as a chairperson together, and we are such a wonderful and beautiful moments to cherish. Thank you so much, ma'am.
Thank you, Apurva.
Uh,
Yeah,
so, can I,
yeah. Harshvardhan,
share the
stop
screen?
share. Please stop share.
So, first of all, at present, I give my regards to respected Usha ma'am, to Meera ma'am, to my dear seniors, Ritu ma'am, Kanchan ma'am, Sarita ma'am, and all the seniors. Girja ma'am is there. So, pranam to all, and thank you so much, my dear friends, my colleague, Madan sir, and definitely Prerna, and they are doing wonderful. And I am very much sure they will win, and they will we welcome them as a chairperson, the next chairperson. So thank you so much. And Madan sir, thank you so much for always including me. So before I start my PPT, what happened? Even just now also, I am in the OPD. And when a patient is coming, a pregnant patient is coming, they are always asking various questions. The questions regarding what they will eat, what they will, the diet they follow, and what not. But they never actually asked about that what whether to have a intercourse during the pregnancy is safe or not. And even as a gynecologist, we are also not giving that advice, because we ourselves is very much confused that what should be the correct thing and what should be not. And this actually today I am focusing on all the myths, all the frequent the myths, misconceptions regarding the sex and sexuality in the pregnancy. And so, my dear friends, intimacy is not just purely physical. It is the act of connecting with someone so deeply you feel like you can see into their soul. That's what is the intimacy. So, the intimacy is not for a recreation. It is also for the procreation. So, to devoid a couple of having not to do intimacy during the pregnancy and is a postpartum, I feel it's a crime. So definitely it's our job that when a patient and when a especially the pregnant lady or after the postpartum when they are coming, we have to advise the correctly what they should do. So when we're talking about the women's sexual function, it is a complex interplay between the physical, emotional, and the psychological factors. To be mother is a natural instinct. Both the pregnancy and sexuality are the natural and the normal phenomena of women's life. So now where the come that knowledge gap? The knowledge gap is that the pregnancy and childbearing is not a disease. It's a normal physiological phenomena. Every women's undergo into that. The couple should not deny it of that pleasure what they are getting into the intimacy. The relationship is actually the part of the quality of life. The women and the couple will have a plenty of questions regarding that what to do regarding sexual activity during the pregnancy, but we are afraid because we ourselves is not aware what should we advise. And many times they are hesitated, they are shy. Even we gynecologists are hesitated and shy to give answers to them. So that's why there is always a knowledge gap. And as we know, there is a change of sexuality during the pregnancy and in the postpartum period. So the patients have a lots of problem, in that, and that we have to deal with. Unless you are familiar of that, what is correct or not, how can we advise them? So this is very important. And when their patients have a confusion regarding what should we do, they are always rely on the Google or the WhatsApp and the Google Baba, and actually it's contained lots of misinformation and they always misguide the patient. So this is very important. So as a gynecologist, it's our responsibility to give the correct information. So women's getting started many advices, reading diet, sleep, what dress, whether they should travel or not, but not about the what they should be the relationship with the partner. So this is and they have the self-imposed abstinence. So by avoiding the sexual intercourse during the pregnancy, during the postpartum, and it's almost 2 years. So it's lead to a disturbed interpersonal relationship. It also increase the extramarital relationship of a husband. So this is very important to deal with. And now coming to the why this is, there is some problem in the intimation during the pregnancy. It is related with the age, it is related with the culture, the relationship, the physical changes, the discomfort, the fear of fetal damage, and definitely the partner sexual function. These all are there. So now the question arises, what is the effect of pregnancy in the sexual function? Yes, it has a effect. It has a psychological effect, because the patient, the pregnant woman, has a decreased self-esteem. There is a anxiety, there is a fear that my baby will get hurt, there is a body disfigurement, there is a previous loss of attractiveness. They are thinking that there is a cultural difference, there is a myths around this, and definitely the interpersonal relationship. There's a physical aspect. The women are having feeling nausea, vomiting, बार बार यूरिन जाते हैं, urinary frequency, low back pain. They are always feeling discomfort जब बच्चा घूमता है पेट में. The fetal baby movements are there. The breast changes are there. Genital changes are there. There is a secretion, white discharge are there. Patients are feeling it's very uncomfortable, and many times they don't want to have intimacy with the husband. So this is very important. These are the physical aspects which they have. But now questions arises, and patients are coming with us. Is the having intercourse during the pregnancy is safe? And when it is not safe, can it harm the baby? Can intercourse cause the abortion? Or is the sex drive is increased or decreased during the pregnancy? And what is the husband views? So now I am here to let aware what is there during the intimacy during the pregnancy. So most of the women can engage in the intimacy activity throughout the pregnancy in absence of any complication. Rather, it will help them to keep the relationship healthy. So, the intimacy or the sexual activity during the pregnancy is a low risk behavior, except when there is a high risk pregnancy or there is a bad obstetrical history. So, now question arises that patients are, will the intimacy or the sexual intercourse will harm the baby? Absolutely not. Your baby is well protected with the amniotic fluid. It will not harm your baby. The mucus plug is there in the cervix, in the opening of the uterus. So it will not, it will help the safeguard of the ascending infection. So yes, they might got mild uterine contraction, but it is self-limiting, and it will within an hours is definitely it will subside. So absolutely
Orgasm may cause
there is no
mild
harm to
uterine
the baby.
contraction, but they will subside.
So what is the advantage? So is there any advantage of having the sexual intercourse during the pregnancy? Yes, it has a psychological advances. The wife is still thinking that मेरा husband मेरा care कर रहा है. So this is really have, and definitely it help in induction of the labor. Why the induction of the labor? The seminal fluids can favor the maturation of the cervix because of the prostaglandin effects. It has a natural prostaglandins. Also, the semen has the immunomodulatory effect. So it's prevent the preeclampsia, and it actually the help in treating the preeclampsia having the development. So these are the facts which the documents are there. So what are the frequently asked questions? So when to avoid intercourse or sexual activity during the pregnancy? At any high-risk pregnancy. What are the high-risk pregnancy? Either the toxemia, the diabetes, the anemia, multiple pregnancy. There's a active bleeding, the abdomen pain, or there's a premature contraction, there's a leaky membrane, the placenta is low lying, there's a previous bad obstetrical history, there is a history of recurrent abortions, there's a previous cervical incompetency, or partner have some active infection like the genital herpes. So these are the conditions where it should be avoided. So is it is normal to don't have any sexual intercourse during the pregnancy? Yes, it's absolutely normal, man. If the husband and wife are comfortable, yes, they can engage into that. If they are not comfortable, absolutely normal. It's they who are decided who आप और मैं कौन है जो decide करने वाले. If up to them. But as a doctor, you have to give advice, the correct advice, that it is actually harmless, harmless, harmless to have a sexual intercourse during the pregnancy unless and until it has some problem in is there. So is the oral sex during the pregnancy is safe? Yes, absolutely it's safe, but avoid blowing of the air into the vagina, because many time it can cause actually it is reported in a few cases it can cause the air embolism, which may be fatal. So this is the thing. Now what is the position? Now again, what I'm always, the position of having the intercourse is, again, it should be decided by the couple only, not only during the pregnancy but every time. So over the course of the time, the use of the man on the top position declined, and women on the top or side by side or rear entry point are practicing more, because it's a more comfortable to the patient, to the wife. So these are the different positions, like women on the top or side wife, or making of the partner lap. So any position, the pressure on the abdomen should be avoided, and deep penetration should be avoided. This is the main mantra. Now, what are the various dysfunction is there during the pregnancy? Yes, in the female, there is a loss of libido, there is a anorgasm, there is a dyspareunia, you can say. The male is also having the low libido, or there is a PE, or there is a erectile dysfunction, or there is a premature ejaculations. And these are due to the fear. These are actually, it is for temporary, because there is always fear in the couple's mind that it might hurt my baby inside the womb. So this is the thing. So now, is there any complications? अभी तक तो सब मैंने गुडी गुडी बोला कि सब अच्छा है. But now talking to, is there any some complication to having the intercourse during the pregnancy? Yes, there is chance of the preterm labor. Theoretically, yes, it can induce the labor, but there is no evidence which clearly suggests that it actually that it has the restriction of the sexual activity is actually beneficial of avoiding the preterm. So it is theoretically can be, yes, it's induce the preterm. What I have already stated, that is there is a contraction, and whenever they are making love and they thinking that they are feeling that there is a contraction, so it's better to avoid it, because it might induce the preterm labor. Prematurity, again, few data are saying, but majority of study are saying that it will not associated with any prematurity or PRM or low birth weight. Now, the fetal distress, there is no overall association between the sexual activity and the fetal distress. Now, coming to antepartum hemorrhage, especially in case of placenta previa, I have already explained that if there is a bleeding, we should avoid it. Even if there is a not bleeding, but it is the like type 2, type 3, or type 4 placenta previa, so absolutely it should be better to avoid the intimacy between the husband and wife. And I have already stated that if there is a vaginal bleeding is there, definitely it should be avoided. Now, pelvic infection, again, I have already stated the mucus plug, very thick mucus plug is there into the vagina, into the cervix. So it will help and it prevent the ascending infection. But if there is some, previously it was there, the active infection is there in the partner, it's definitely it should be avoided, or unless absolutely can do. Now, the venous air embolism, again, it is very, very, very rare, but potentially life-threatening, and it is due to the oral sex, especially when there is a blowing of the vagina with the air, then it can cause the venous air embolism. So now coming to the postpartum period, so wait until the bleeding stop completely and wound heal completely, then definitely can they have the intimacy. And normal ovulation or involution of the genital tract has occurred, then they can start the physical activity. One is physically and emotionally ready to have the intimacy with the husband, then definitely they can do it. And definitely use of contraceptive is very important. As a doctor, as a gynecologist, it's our advice, we should advise is to have a contraceptive. So most of the studies advise that to have an intimacy, to start the sexual activity after 6 to 8 weeks after the normal delivery, or either the cesarean or instrumental delivery. So advice to the patient, try just cuddling and just gradually then have a sexual arouse. Then the plenty of foreplay should be there. Apply the lubricants. Baby nap time is the best time. Also, when patients are always coming that my pelvic floor is very weak after the normal delivery, so advise them to have a Kegels exercise. There may be certain amount of dyspareunia. If they are feeling, call to your doctor, definitely visit your gynecologist, drink plenty of fluid, eat well, rest well. Then only when they are feeling comfortable, then making love is actually very important. So at the conclusion, give accurate information and remove the myths and misconception. Discuss about the matter to the couple is very important. Let them decide what they want to do. As a doctor, it's our advice, our duty to give advice them the correct information. Counseling is very part. Why very important? To relieve the all the anxiety of the couple is very important. So for any query, definitely we are always there. Thank you so much and God bless.
Thank you, Dr. Apur, for that excellent presentation. And you really brought really insights, into all the myths and understanding, which really lacks in us, I think, in our patients, it's too much. And we should, I think, keep sharing to our patients so that this journey becomes a joy for them. So that was excellent. And my regards to Kurkoti sir and Vipin Pandit sir. We had a fantastic tenure. It's my vice president and our most respected and humble, our chief guest, Chief guest Usha Sharma madam and Meera Agnihotri madam. And also we are missing our inspirations, Narendra sir, Chandravati madam, and Dynamic Preeti. What to say of our conveners today? Madan Kamble and Prerna and Apur. I think I'm so happy to see, all of them. They are real friends who are so energetic, so versatile, and you're always coming up with such thoughtful, academic programs. I could not imagine this sexual health committee could do so well, and even the YTP committee is doing wonderful today. And all of you, Dr. Madan, Dr. Prerna, very, very innovative, and I've seen you working so passionately, and I think you're doing a wonderful job and wishing you all the best for your endeavors in future, your chairpersons and your coming elections. So all the best, Dr. Madan, Dr. Prerna, and thank you so much for having me here.
Thank you.
Thank you so much.
Hi, Dr.
Thank you
Prerna.
so much.
I am here now. I can talk. First of all, thank you for keeping this UPCUT and AMOGS webinar, especially for the very untouched topic. And the program's topics are very good. And Dr. Apurva, we all know that he is a dedicated worker. So as he said, and we all obstetricians and gynecologists should know that our women, this is a topic where our women and our patients, they don't they speak with comfort. So we have to make an environment that they can talk, and especially if there is some bleeding or some discharge and leaking, then of course they can't do the intimacy. Otherwise, they can, and we have to give them proper information and proper support. So thank you very much, and thank you and congratulations on a wonderful organization.
Thank you, ma'am. Wonderful backdrop you have, ma'am. We also have Seema ma'am and Kanchan ma'am with us for their inputs.
Yes, Prerna already commented that Apurva speaks in its perfection, and I think each and every point he has covered well. This is a very important point which patients many times do ask to us. They are coming back, मैडम सेक्स के बारे में बताइए, प्रेगनेंसी में क्या, किस ट्राइमेस्टर में कैसे. They are now more and more aware. So if you know well, you can guide them well, and this is a very important point. Thank you for making me.
Thank
Thank
you,
you, ma'am. Thank you.
Thank you, ma'am. Thank you so much.
Okay.
And
ma'am.
so,
Seema?
yeah, thank
Dr.
you
Seema.
very much. And thank you, Dr. Apurva, for a very enlightening and a thoughtful presentation. And as our mentors, Dr. Usha Sharma ma'am and Meera Agnihotri ma'am had mentioned that this topic is often under-discussed. Neither the patient nor the treating doctors talk about it. And patients are shy and hesitant, and the doctors are confused. So, as you rightly mentioned, Dr. Apurva, that the patient often rely on Google Baba for the information, and therefore it becomes our duty to provide them the right information. So today's discussion, your discussion, has helped us understand that the pregnancy is not only a physical journey, but is also an emotional one. So the need of the hour is to increase awareness, and not only amongst the patients, but also amongst the doctors on this important topic. And therefore, we should plan more meetings on this important topic. And so thank you, Dr. Apurva, for this enlightening session. And I'm sure this today's discussion will positively influence our counseling of the patient and our counseling of the patient in the daily practice. So thank you once again. And thank you, Dr. Madan and Dr. Prerna, for making me part of this important meeting. And so, I think this is one of the first webinars on sexual health that I'm attending. So very enlightening one. And even my awareness improved about the sexual health. So would love to attend the entire webinar. And all the very best for your upcoming elections, Dr. Prerna and Dr. Madan.
Thank you, ma'am.
Thank you.
Thank you
Thank you
so
so
much,
much.
ma'am. Thank you so much, ma'am. Thank you so much.
Dr.
And
Shweta
all the
would like to
best,
say something.
Prerna. Yeah,
Thank you,
sure.
Apurva.
Yes.
Shweta, you'd like to
As
comment something
everybody
on
has
the talk?
already said, ये मेरे लिए भी बहुत सारी चीजें आज आई ओपनिंग थी और regularly patient keep on asking, especially after delivery, how when and how we can resume sex, especially females, and sometimes even husbands ask. So if we have knowledge, then only we will advise to our patients. So it's very much eye opening and very informative session for me also. Thank you, Dr. Apu. Thank you, Dr. Kamle. Thanks for it.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you,
Thank
Dr.
you, ma'am. Thank you.
And all the best for
Thank
your upcoming elections also.
thank you, ma'am.
Thank
With
you.
this way, we conclude the very first session, and thank you, Dr. Apurva, and all the chairpersons. It was indeed a very elaborate, exhaustive, and very, very informative session on a much less talked for topic on sexuality in pregnancy. And I expect all delegates might have benefited out of it. So we move on to our next session, that is on genitourinary syndrome of menopause. So when we speak about this GSM of menopause, there is so many things that are uncovered. There's so many things that are unspoken. The unspoken problems of this particular age on menopause, where we need to dig in. These particular females, they usually come with either a stress urinary incontinence, or maybe they will come up with some sort of vaginal burning or something. But then when we dig into the details of these patients, there's so many things that are still not discussed. So we need to understand in detail what is GSM of menopause. And for this, we have none other than our very well beloved speaker, Dr. Sanjita Dubey. And to chair this session, we have Dr. Priyanka Garg from Meerut Society. Can we have the CVs of the chairpersons, please? Dr. Suchi Jain from Varanasi Society. Dr. Shubha Harshvardhan, can you play the CVs of the chairpersons? Dr. Shubha Singh from Jaunpur Society. Dr. Nilima Agarwal from Mathura Society, and Dr. Reshma Nigam from Kanpur Society. Can we have the CVs of the chairpersons?
Ma'am, is my screen visible?
Yes, it is very much visible.
Okay,
Harsh.
sure.
Can we have Dr. Priyanka ma'am CV, please? Yeah. Uh, yes, the previous one. Yeah. Dr. Priyanka ma'am, ma'am, we are so very honored to have you amongst us. Ma'am is associate prof of LLRM Medical College, Meerut, and has a lot of awards and affiliations to her credit. We welcome you, ma'am, to this wonderful session. We have Dr. Suchi Jain from the Varanasi Society. Suchi Jain, madam, is a life member of many prestigious organizations, and she's an associated professor of Department of OBGYN and IMS BHU. We welcome ma'am for your esteemed presence. We have Dr. Subhash Singh ma'am. Dr. Subhash Singh ma'am, Dr. Subha Singh ma'am is the president of the Jaunpur OBGYN Society and is a consultant Harshit Medical and Research Center, Jaunpur. We are so very honored to have you amongst us, ma'am. Dr. Nilima Agarwal ma'am from the Mathura Society. Ma'am is the Yes, why are you back? I'm doing, yeah, it's Dr. Nilema Agarwal, ma'am, is the secretary of the Mathura OBGYN Society and presently the consultant at Sri Krishna Hospital, Mathura, Uttar Pradesh. And we also have Reshma Nigam, ma'am. Reshma Nigam, ma'am, is from the Kanpur Society. Ma'am has a lot of awards and credits to her affiliation, and she is a life member of different reputed international organization with special interest in advanced ART and IVF from Sri Gangaram Hospital, New Delhi. Ma'am, we welcome you, and we are so very honored to have a string of stalwarts as our chairpersons for this very revered talk by Dr. Sanjita Dubey from Noida Society. Can we have one of our chairpersons to introduce our speaker, Dr. Sanjita Dubey? And just a word for Dr. Sanchita, she is one of my co-member for the Safe Motherhood Committee, and she is very, very learned and beloved and a darling friend also. And also known for her grace and smile and her beauty beyond accolades. Welcome, Dr. Sanchita, and over to you, chairpersons, for introducing our speaker.
All right.
Can we have? Yes. Can we have one of our chairpersons, Dr. Suchi, Dr. Nilima, anybody who can introduce Dr. Sanchita formally? Or else I'll do the honors. So Dr. Sanchita is the president of Noida OBGYN Society, apart from being my beloved friend and a charming face in Foxy. I had suggested once Dr. Sanchita to go for the Mrs. India, Mrs. Universe contest, but she somehow somehow dropped the idea. Dr. Sanchita, you can very well think about it. So she's a joint secretary of NOGS and also vice president NOGS 1925, and has a lot of academic awards and credits to her affiliation. And we welcome you, Dr. Sanchita, for this very important
Thank
topic.
you.
Over
Thank
to
you,
you.
Prerna, for boosting my morale before I start my presentation.
मैं कुछ
So,
बोलूं?
the first
Ultimate
thing is,
combination of beauty and brain. The
thank
perfect
you,
person for
Dr. Madan.
aesthetic. Perfect person for aesthetic guy.
The first thing is, I would really like to congratulate both of you and Dr. Apurva for organizing such a sensitive and a less spoken topic, which awareness among the women is later, the awareness among the clinician is the first priority we should go ahead with. And so I'm very happy that we are talking about such a sensitive topic. And, this is something which we have not discussed in our PG curriculum. So this should be a part of that also, so that we are not hesitant in discussing this with our patients. Shall I go for screen share?
Yes, please. Not getting shared.
I don't know. I have to leave the meeting and then join again. I'm
No,
not
you
sure.
can just put it's showing that arrow, no?
Leave meeting. Okay, just a minute.
You have opened your PPT
Yeah,
in
my
your
PPT
laptop?
is on my laptop only.
Harshvardhan, make her co-host. Harshvardhan, make her co-host.
Yes, sir. Yes, sir. Just a second.
Hello.
That may
Please
be the
come
problem.
down.
क्या दिक्कत आ रही है?
आ जाओ 1 मिनट के लिए आ जाओ.
Yeah.
Sanjita ma'am, you are co-host now.
Okay.
Then you try sharing. Yes.
Okay.
Yes, we can see it now. Make it slide mode.
The screen is visible?
Yes.
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 Okay. All right.
Make it slide mode. That will be
Yeah,
nice.
I'll do it. Slide share. Is it visible?
Yes. But it's coming in fragments, so you have to just click
All
on
right.
that
Okay.
that icon, that slide icon.
Slideshow. I'll do it slideshow, right. Just a minute.
Yeah.
This is fine?
Yeah. Done.
All right. So, see, when we talk about genitourinary symptoms of menopause, so this is a term which was coined in 2014, which has been replaced by vulvovaginal atrophy, atrophic vaginitis, and urogenital atrophy. So this is a chronic and a progressive condition which affects the vulvovaginal sexual effects and the lower urinary tract part of the woman. So primarily it is caused by the estrogen deficiency commonly seen in postmenopausal women, but can also affect a premenopausal or a perimenopausal woman. See, why it is important for us to discuss this here is it is actually underdiagnosed, and we need to make our women aware of it so that we can help them in coming up with the symptoms. And we all should be aware, we as gynecologists and the healthcare professionals should be aware of this term and the problems related to it so that we can help our women when they come with the problem. And that one which I have recently started asking a leading question whenever I see any woman of this perimenopausal age or postmenopausal, I always ask them leading questions regarding the GSM, so that if they are hesitant, you can just sit with them for 2 minutes extra and discuss their problem so that you can help them accordingly. So when we talk about GSM, it is basically categorized into three terms: genital, which leads to vaginal dryness, irritation, some discharge, thinning of the vaginal mucosa, and the vaginal vault prolapse. Sexual effects may be dyspareunia, reduced lubrication, postcoital bleeding, loss of libido, and dysarthria. Urinary symptoms may lead to dysuria, urgency, stress, urgency, incontinence, or recurrent urinary infection, urethral prolapse, or ischemia of the vesical trigone. So it is very commonly noticed in our women that, they discuss it with their peer group. Okay, you are having a problem, I am also having a problem. Okay, so this is something which we need to adjust and we need to go with it. So you have to assure your patients that, this can be treated. You don't have to just, live on with it. So the pathophysiology involves the loss of libido, vulval thickness, the decreased collagen elasticity, blood flow, reduced vaginal discharge, reduced pubic hair, reduced labial minora, hymenal tags, decreased vaginal cell glucagon, which leads to change in the vaginal microbiome and increases the pH. Decreased vaginal flow strength and control, dry and thin epithelium, short and narrow vagina, prolapse, decreased bladder capacity and sensation, and vaginal hypersensitivity or decreased feeling. So before, just going into the theory, I would like to discuss certain case scenarios which will make us the symptoms more understandable, and how to approach with each and small symptoms with the woman comes to us. So this is a 62-year-old woman. She had a symptom of recurrent UTI, 4 episodes in 8 months, urgency, dysuria, mild incontinence. She had a history of menopause at the age of 50 years. There was no history of HRT taken, controlled diabetes for last 10 years. On examination, we could see an atrophic vaginal mucosa, urethral tenderness, and no significant prolapse. So on investigation, urine culture was positive for E. coli. Post-void residual volume was not there on ultrasound. So how does the question arises, how does the estrogen deficiency contribute to recurrent UTI in postmenopausal women? Of course, it leads to thinning of the vaginal mucosa, urethral mucosa, which increases the susceptibility to infection. There's loss of lactobacillus, higher vaginal pH, which facilitates the pathogen growth and weakens the local immune response and decrease the ability to fight infection. Reduce urethral closure pressure because of the laxity of the vagina and the bacterial ascent to the urinary tract. What is the role of vaginal microbiome altering the recurrent urine infection? So we nowadays, a lot of vaginal probiotics are available, which are actually very, very effective in these women of postmenopausal age group, because this will prevent this will improve the microbiome of the vagina, plus it prevents the infections also. So what happens is there's loss of lactobacillus dominance, which increases the E. coli colonization, and how to restore it is to start the estrogen therapy, a local estrogen to enhance lactobacillus growth, probiotic, avoid unnecessary antibiotic usage, and dietary intervention also helps. So when should we consider local estrogen therapy, and what are the contraindications? That's the main question. So we as gynecologists should not be afraid of, prescribing the estrogen in women. Local estrogen is very, very safe. But of course, you should do a preliminary all investigations, and the history should be taken in detail so that you can start with the estrogen therapy for them. So what is recurrent UTI? If it is more than 3 UTIs in 12 months or more than 2 in 6 months. The presence of genitourinary symptoms of menopause, which leads to vaginal dryness, dyspareunia, urgency, or dysuria, atrophic urethritis, or increased post-void residual volume. The contraindication, of course, if she has a history of any breast cancer, endometrial cancer, which is estrogen sensitive, or there is unexplained vaginal bleeding or severe liver disease, then you should not give any, even the local therapy should be avoided. Non-hormonal, there are a lot of non-hormonal treatment modalities available. D-mannose, which prevents the E. coli adhesion to the bladder, cranberry extract, which inhibits bacterial adherence, probiotic, which restores the vaginal flora, hydration, bladder training to reduce the bacterial colonization, vaginal moisturizers to maintain the mucosal integrity. Then how should we manage the antibiotic resistance in cases of UTI? We should be very, very precise in giving any antibiotic for any vaginal infection. One, the patient comes with symptoms, we need to evaluate whether this symptom is actually related to the urine infection. So always go for a culture test. If there is culture positive, then only give the antibiotics. Otherwise, do a good local examination. It may just be atrophic vaginitis or just some other reason which is leading to this burning or the symptoms of UTI. So you have to be very precise in diagnosing it, then only start the antibiotics. So we have to restrict the use of antibiotics to prevent the resistance. Low dose prophylaxis can be given with the nitrofurantoin. We all know that. The alternative approaches involve methenamine, which prevents bacterial growth in the bladder. There are some therapies which may be of use, like intravesical hyaluronic acid or chondroitin sulfate usage. And this I have emphasized that we should always reduce the usage of antibiotic. So at the end, a case like this who comes with recurrent recurrent UTIs, estrogen therapy is one, local estrogen therapy, which can be of a use, which helps in restoring the vaginal microbiome. It's a key to prevention. And non-hormonal strategies are also equally effective. And of course, we need to restrict the use of antibiotics. The second case which we would like to discuss here is a woman with 57 years of age. She had a symptoms of persistent vaginal itching, burning, occasional discharge, and for past 2-3 years. And she has a history of menopause at 51 years of age. Occasional, there was urine urgency, no hormonal use, history of hysterectomy for fibroids. On examination, the local examination, it was thin, fragile vulvovaginal mucosa, loss of elasticity, mild arrhythmias, but no significant discharge. On investigations, it was negative for vaginal culture. Vaginal pH was 6.2. Wet mount showed minimal lactobacillus, normal glucose levels. So there are two things. One is a genitourinary symptom of menopause and chronic vulvovaginal infection. Whenever a woman comes with these symptoms, like it's a dryness, irritation, dyspareunia, you always check, you should check for vaginal pH. If it is more than 5, then it is definitely GSM. If it is the vaginal pH is normal and there is a discharge, itching, there's a foul smell, then it goes into vulvovaginal infection. Number of times, patients come with the infection. One will give one antifungal, they will go to another gynecologist, they will give another antibiotic. Sometimes for vaginal itching and all, we refer to dermatologist also. And the patients keep shuttling between the gynecologist and the dermatologist. So now, since we are the first one to approach, I mean, the woman approach the gynecologist first, so we should have answer for her this problem. So now when you keep this GSM term in your mind, I'm sure you will be able to help your clients regarding these symptoms. So whenever any woman comes with multiple courses of antibiotic usage or things like that, you should always stop everything, take a detailed history. You can do a simple vaginal pH testing, which is not difficult. It can be done in OPD, and you can come to the diagnosis of GSM and treat her accordingly. So vaginal pH more than 5 suggests estrogen deficiency, lack of lactobacillus increases infection susceptibility, and microbiome testing helps in distinguishing between the dysbiosis or from true infection. There are not only estrogen therapy, there are a lot of non-hormonal alternatives like hyaluronic acid, vitamin E, probiotics. So hyaluronic acid improves the hydration, reduces the irritation. Vitamin E supports the epithelial healing. Probiotic restores the vaginal microbiome and acidification, which helps in further infection, or it helps in improving the vaginal mucosal integrity also. So the most important barrier in treating these patients is lack of awareness among us as clinicians and over-reliance of antifungal, patients' reluctance to discuss this problem and the symptoms. So what happens if the patient ever comes to you, you should always, sit and give 5 minutes extra to understand her problem so that you can help her better and you can avoid usage of too many antibiotics. So the next case is a 60-year-old female. She comes with history of urinary leakage with coughing, laughing, urgency, decreased arousal, loss of orgasm, and painful intercourse. Menopause was at the age of 53. She had a history of 2 vaginal deliveries, mild hypertension, sedentary lifestyle. On examination, there was decreased vaginal elasticity, atrophic mucosa, mild anterior vaginal wall laxity. Urodynamic study was done in this case, which suggested mixed incontinence or urge incontinence component. So you don't have to go for the urodynamic studies. It is very simple with the history, how to differentiate between the stress incontinence, urge incontinence, and usually patients have mixed urinary incontinence. So we just need to take a detailed history and understand what is happening. It's very simple: leakage of urine while coughing, sneezing, running, lifting, a weak pelvic floor. It suggests stress incontinence. Uh, it is a very typical symptom. The woman says that once she feels the urge of passing urine, it becomes very difficult for her to hold, even reaching the washroom, or even getting ready to sit on the toilet seat. She doesn't have time and she leaks involuntarily. So this is urge incontinence. And of course, there are a lot of times where it is a mixed incontinence. So what is the best first line non-surgical treatment for mixed urinary incontinence? Of course, the first line is pelvic floor muscle training and bladder retraining, fluid management. And nowadays we have very good vaginal laser therapies and PRP in selected cases, which has a very, very promising results in treating the symptoms with SUI and urge incontinence. So how does GSM impact sexual dysfunction? So this woman had one, stress incontinence, and second, the sexual dysfunction. So how does it affect? It leads to vaginal dryness, which leads to dyspareunia, which leads to reduction in libido, because of course she starts relating the intercourse with pain. So that leads to reduction in libido. So local estrogen therapy or the local application with the injecting hyaluronic acid also improves the lubrication. Pelvic physiotherapy, of course, has got a good enhance in the sexual function. What counseling strategies can help women overcome this stigma? As I said, just give her 5 minutes extra, make her comfortable, ask some leading questions, whether she has this urinary incontinence or she has some problem in sexual intercourse. So as Dr. Purva has said, that pregnancy, we should not deprive them from this. Same thing applies in the postmenopausal age group. We should not deprive them. This is an important part of life. So they should be open up in discussing it, and they should continue having their good sexual healthy life. And I think we will be discussing about the psychological aspect. So of course, multidisciplinary management is what is required. So how should we approach a woman who has got mixed urinary incontinence? Of course, local estrogen therapy, pelvic floor muscle therapies, intravesicular botulinum toxin, surgical, which is not everyone is doing it, and I think now with this lasers and PRP, which are giving us a very good promising results, we can totally avoid the surgery for SUIs. So in the end, I would just to conclude for this particular case, it is estrogen therapy, pelvic floor dysfunction, sexual health, role of lifestyle modification. Yes, of course, we should not forget the role of more lifestyle modification in treating such cases. And then SERMs, laser therapy, all these things have good promising results. So we should just discuss all these options with the patient who comes with such problems. The last case, I'm going to be very brief on this. It's basically a repetition of what we have discussed, but I have put this case especially because this woman, she was a case of breast cancer who had been on anti-estrogen tamoxifen for last 5 years. So she came with vaginal dryness, burning, dyspareunia, and frequency of UTI. So this has combination of everything. Now, on examination, there was a positive culture for E. coli, and she had a vaginal pH of more than 6. What is the safest option for managing this patient who is a breast cancer survivor? Of course, the first choice would not be an estrogen cream. So we should opt for vaginal moisturizer, hyaluronic acid, or laser and PRP is safe in post-cancer patients. So we should always offer them such treatments. In severe cases, after consulting, so local estrogen is not absolute no for these cases. You can always discuss with the oncologist and keeping them in the loop. If required, you can give them low dose vaginal estriol for some time to relieve the symptoms, and then you can continue with the non-hormonal options. The quality of life, yes, matters now. A lot of young women also are facing with breast cancer. So we need to, and then post chemo and radiation therapy, they do face symptoms like this. So we have to individualize the treatment plan and patient input, a shared discussion with the oncology team, and of course, the priority will be non-hormonal strategies, but for short period and low dose estrogen therapy can also be offered to such patients. How effective are non-hormonal interventions? They are good. I mean, for temporary relief, you can get good results with vaginal moisturizers. And in these patients, if you go for laser therapies and PRP, then it will give a long-term effect and she will be relieved from her symptoms. So therapies for genitourinary symptom of menopause, the first and foremost is lifestyle management, vaginal lubrication, moisturizers, or laser therapy, oral SERMs, or local estrogen therapy, vaginal vitamin E, probiotics, vaginal probiotics, oral estrogen or subcutaneous implants, vaginal patches, or transdermal patches, and at times, DHEA and testosterone is also very effective in treating GSM cases. So I haven't covered the psychological aspect of it because that we will be discussing in our next panel discussion. So at the end, I would just like to emphasize certain points that GSM is a common but underdiagnosed condition affecting postmenopausal women. Early recognition and intervention can improve quality of life. Non-hormonal and hormonal therapies offer effective symptoms. Emerging treatment like SERMs, lasers, PRP are also need further validation. But yes, we have now last few years, we have started getting the results and that gives confidence to our treatment strategies. So again, I would like to emphasize that first, awareness among us as healthcare professionals, as gynecologists. Okay, these are the symptoms which should be treated by us. No UTIs should be referred to urologist. We should handle this. Recurrent UTIs should be handled by gynecologist. Itching, dryness, everything in the vulval area should be managed by gynecologists. We should not keep shuttling the patients between the dermatologist, urologist, and a gynecologist. We should be ready with the answers and help them with all their issues regarding these genitourinary symptoms which are related to perimenopausal and menopausal women. Thank you very much.
Thank you, Dr. Sanchita. That was indeed quite an exhaustive, informative, and quite an elaborate talk on a very pertinent subject of GSM in menopause. And over to the chairperson for their expert inputs. We have Dr. Priyanka, Dr. Suchi, Dr. Shubha ma'am, Dr. Reshma ma'am.
I would love to hear from Dr. Poonam. Dr. Poonam, you're mute. Ma'am, आप unmute करिए.
Yeah. That was really an eye-opener sort of lecture. And yes, we would be discussing about the psychosexual aspects, but the remaining part has been exhaustively covered by you. Very good lecture.
Thank you.
Reshma ma'am, you're there.
Yes, it was an excellent presentation, and best part was it was totally real case based and include all the treatment modalities and the management plans. Thank you. Thank you so much.
Thank you, ma'am. So thank you, our esteemed speaker and our esteemed chairperson for this very wonderful session. And we now move on to our next scientific on the platform. This is a panel discussion on psychosexual crisis in midlife, and I hand it over to Dr. Madan Kamble, my co-moderator, to kindly take up the session. For this, we have experts, Dr. Poonam Mishra, ma'am, for Lucknow Society. Ma'am, can we have ma'am CV, please? Poonam Mishra ma'am is one of my very, very beloved, very loving. She's like a Didi. I would like not to call Poonam ma'am always when I remember and whenever I happen to call Poonam ma'am is like, how are you, Didi? So this is the love that we share.
I would love
So
that. I would love that. I would love to be
and
called
this is a
that.
love that we share, and she's a pioneer in the field of aesthetic medicine now, and doing so much so for female regeneration therapies and functional as well as aesthetic gynecology, that is known as the FRAG. This is the functional regenerative and aesthetic gynecology. Ma'am is one of the pioneers in India, and we welcome you, ma'am, for this very esteemed session on psychosexual midlife crisis. And none other than you would have been the right person to have this panel expert being there with us. Thank you so much, ma'am. We have our esteemed panelist, and over to you, Dr. Madan Kamble, to invite our panelists and introduce them.
Yes. Harshvardhan, please stop share. Yeah. No. ठीक है, it's okay.
Okay, sir. I've stopped the share now.
No. All slides are there, no?
Yes, sir. Yes, sir. All slides.
Yeah. Now please share the CV deck. Yes, we have got the eminent panelist, Dr. Mithi Bhanot. Ma'am is a senior consultant at Apollo Hospital, Noida, and she is the secretary of Noida Vijay Society. Welcome, ma'am. Next. Yes, Dr. Sanchita Dubey, ma'am. Just we have heard her. She is the president of Noida Obs and Gynae Society. Welcome, Dr. Sanchita. Next. Yes, Dr. Shalini Tandon, ma'am, who is the president of Varanasi Obs and Gynae Society, and also vice president IMA Banaras branch, director at Tandon Multi-Speciality Hospital, Varanasi. Welcome, Shalini, ma'am. Yes, Dr. Sudeep Kaur. She is the aesthetic gynecologist at Moradabad and past president of Moradabad OBGYN Society and very dear friend of mine. Yeah, welcome, Dr. Sudeep. Next.
Thank you so much, Dr. Madan.
Yeah, Dr. Manju Prabhakar. Yeah, ma'am is life member of Stillbirth Society of India, life member of UP chapter, life member of FOXY, and president of Muzaffarnagar Obs and Gynae Society, and also member of Menopause Society. Welcome, ma'am.
Thank you, Dr. Madan.
Yeah, Dipali Verma, ma'am, who is the president of Moradabad OBGYN Society, certified by Fetal Medicine Foundation, ma'am. Yeah, ma'am is so active president of Moradabad. Welcome, ma'am.
Thank you, sir.
Yeah.
It's very well going here, sir. Thanks.
Yes. Dr. Varija Seth, ma'am. Ma'am is the senior Obs and Gynae consultant in Lucknow. She has special interest in laser cosmetic gynecology and sexual medicine.
Thank you.
Welcome, ma'am.
Thank you.
Dr. Neha Chandra, ma'am, who is the Honorary Secretary of Moradabad Obs and Gynae Society. She has 12 years experience in Obs and Gynae. Special field of interest is infertility and high risk obstetrics. Yeah, welcome, Dr. Neha.
Thank you, sir.
Dr. Kalpana Dikshit, ma'am, is the Senior Obs and Gynae Consultant. Presently, she is the President of Kanpur Obs and Gynae Society. Welcome you, ma'am. Next. Yes. Yes, I welcome all the esteemed panelists and especially dear Poonam, ma'am, as an
Thank you,
expert.
Dr. Madan. Thank you for
Yes.
giving me this opportunity.
Love to meet you always, offline and online.
Thank you. And it's so nice to see all the friends over here and seniors. Hi, Sudeep, Dr. Sudeep Kaur, or Varija from my own city.
Hello.
Hi. And
Hi,
Sanchita,
good to hear from
Dr.
you.
Sanchita, and everyone. Yeah, I welcome you all. Esteemed panelists. Yes, we should go ahead.
Yes, Chala.
Yeah.
We have specifically chosen this topic, that is psychosexual crisis at midlife. We know what is the period called midlife and what are the problems, psychological and sexual problems, that we are going to discuss. We know this period is generally between 40 and 60. And at this point, there are so many fluctuations in the so many aspects like moods and behaviors. People tend to reevaluate their lives and confront their own morality. And also, this crisis can affect self-concept and self-confidence, which leads to changes in the moods, behaviors, emotions, and relationships always. We all know the sexual function is an important component of quality of life. And what this midlife does, uh, it has many challenges to optimal sexual function and intimacy for women. So, sexual function is always correlated with overall well-being and relationship satisfaction. And these sexual dysfunctions are many times under-recognized and under-treated by the healthcare providers. There are so many reasons behind this. Let us know what is the normal sexual function before understanding the sexual dysfunctions. Grossly, it can be said that it is a complex interplay of physical, emotional, and psychological factors between the couple or the partners. And sexual response cycle that we have to understand, that is the fundamental interplay between the mind and body. This is the cross definition. There are 4 phases of sexual response cycle, main 4 phases, that is the desire, arousal, intromission, and orgasm. And the female sexual dysfunction is divided depending upon these 4 phases, like desire disorders, arousal disorders, orgasmic disorders, and sexual pain disorders. This is the Master and Johnson's linear model of sexual response cycle. We are not going into the details, but this is the linear model, and this is the Rosemary Besant's non-linear model, that is the circular model, which is mainly based on the intimacy, because intimacy is at the center. Let us go ahead for the first question. What factors affect the sexual function? Dr. Sudeep, may I have your opinion about this? Which factors affect the sexual function?
Thank you, Dr. Madan, for making me a part of this panel. So, there can be many factors which affect sexual function. Like there can be biological factors, as we already had a talk about the genitourinary syndrome of menopause. It can be one of the biological factors, or there can be vulvovaginal atrophy, which develops after menopause, or there can be pelvic organ prolapse, uterine prolapse, cystocele, rectocele, that can cause a sexual dysfunction. Also, patient can have certain medical problems, like she might be having hypertension, she's a diabetic, she's having chronic renal failure, or she's having certain cardiovascular problems, or certain neurological problems like stroke, and or patient can be having a breast, ovarian, uterine or any cervical cancer, or patient is having urinary incontinence. All this can also lead to sexual dysfunction. Also, there are certain medications, if they are being prescribed to the patient, they can also have certain disharmony in the sexual function. Like if the patient is on antihypertensives, especially the beta blocker ones, or if the patient is on antidepressants like SSRIs, or if the patient is taking opiates or benzodiazepines, then also the arousal and the response is delayed. Or if the patient is having certain drugs like anti-epileptics, anti-cancer drugs, they can also create problems in the normal sexual function. And also, as you rightly told in the definition, that it is all about physical, emotional, as well as psychological thing. है ना? So, psychosocial factors can also affect the sexual function. Like there can be certain mood swings, or there can be career or family stress, which affects the sexual function, or there can be any history of trauma, especially sexual trauma that the patient had undergone, which can cause such type of problems. And also, there can be interpersonal factors between the couple. Like the couple is aging, that might be a problem. They might feel that they are not looking that attractive that they used to be before this mid sexual life. And there can be marital disharmony, or there can be loss or gain of any of the partners. So these are certain factors which can cause a sexual dysfunction.
Yes, Dr. Sudeep, you are rightly pointed out all the aspects which are affecting, so many factors affecting the sexual function. So there are so many symptoms as regards the menopause. We all know this because we are practicing day to day in our day-to-day practice. There are so many cyclical changes are there: hot flushes, tiredness, poor sleep, loss of libido is there, anxiety, loss of memory. As far as the sexual problems are concerned, there is dry vagina, uh, discomfort is there during the intercourse. In many cases, at least 50% cases, these are the symptoms which can create the sexual dysfunction in that particular female. So, what happens in the menopause, the vagina before menopause and vagina after menopause? There are so many changes in the vaginal wall thickness, moisture, flexibility, and regarding the blood flow. That is why these symptoms are coming. There is loss of enjoyment of sex and loss of intimacy also. The next question goes to Shalini ma'am. Would like to hear from Shalini ma'am that how sexual dysfunction affect the quality of life. We all know that it definitely affect the quality of life. How it affects? Yes,
Good.
Shalini.
A very good evening to everyone who are attending this webinar. And first of all, I would like to thank you, Dr. Kamble, for making me a part of this webinar. So, to discuss the effects of sexual dysfunction on the quality of life, it affects the quality of life in multiple ways, because it may lead to depression, anxiety, and frustration in the women. It also leads to marital disharmony. There may be disturbed family life of the woman. Her relationship with her husband may be disturbed, and she may also be very irritable with her children, with her family, because she's not happy at the bottom of her heart. She's not so happy, and she's not so contented with her life. So it disturbs the psychology of the woman a lot, and so it affects the whole family. And she may also develop the sense of futility.
Shalini ma'am.
Hello.
Hi ma'am. Hi.
Sorry to
So nice
mention
to see you here.
recently added in my close friends list. So
Yes.
nice to see you here.
So nice to see you.
Yeah.
Poonam ma'am, would you like to add something?
Mm-hmm.
Would you like to add
Yes,
something?
definitely. I would like
This
to
point?
add something.
Yes.
See, aging has affected the sexual life so much that the WHO has declared it the decade of healthy aging, because healthy aging is a must for all the midlife couples and aging couples. So 2020 to 2030 is the decade of healthy aging. And yes, we are discussing about the, the sad aspects or the side effects of the aging over the sexuality of these couples. But I would like to add a few lines only that yes, the liabilities are done, kids are settled, and all the things are now settled once कहते हैं ना जिंदगी स्मूथ हो गई है. तो this is the another aspect of these couples. They are actually more conjugal, they are more interested towards each other if they are having personal spaces in their families. Otherwise, what happens are aging couples are always, their bedroom has been taken by the growing children or the first couple in the family, the newest couple in the family, or फिर वो सास ससुर को बाहर निकाल के ड्राइंग रूम में छोड़ दिया. तो those who are having proper spaces with them, they spend a good time with each other. And then the problem arises. They want, it is just like the second honeymoon in their life. And now they are cozy with each other. And they find that yes, the male is suffering from erectile dysfunction. He takes more time for the arousal. Female also needs more time for arousal. And she is having problems during because of these dry vagina and all. So the fact is that they are more close together, more close towards each other, and then they are having such kind of difficulties and they need the treatment. Yes.
Rightly highlighted, ma'am. All these points are true, actually true.
True.
And one thing is that these female sexual dysfunctions are going to affect on male also. There is, as you have rightly said,
Effect on male.
premature ejaculation, ED, divorce, and sometimes extramarital relations too. Yes. As far as the classification of female sexual dysfunction is considered, this is the old classification, and right side, this is the new classification, that is DSM-4 criteria and DSM-5 criteria. DSM-5 criteria for female sexual dysfunction is the latest classification. According to that, the female sexual dysfunctions are divided into three main types. That is the sexual interest arousal disorder, orgasmic disorder, and genitopelvic pain penetration disorder. In the old classification, there were four main types: sexual desire disorders, arousal disorders, orgasmic disorders, and sexual pain disorders. Prerna, would you like to take?
Yes, yes.
Yes, please.
So once again, warm welcome to all our string of esteemed panelists and our expert. As we take on this panel ahead, this very pertinent topic of female sexual interest or arousal disorders, we need to just emphasize that there is persistent or recurrent loss of desire in sexual activity, sexual thoughts, and sexual stimulation that causes heightened stress in this woman, and the incidence is as high as 10%. So, can anyone, any of our panelists, Dr. Shalini ma'am, Dr. Manju ma'am, Dr. Varija Seth ma'am, can enforce on this criteria of female sexual interest disorders and arousal disorders? Dr. Varija ma'am, you can take this up.
Yeah, based on this criteria, there has to be criteria about the sexual interest, and erotic thoughts must be decreased. And then there are new criteria where there is absent or decreased initiation of activity and excitement and pleasure during sexual activity, arousal in response to sex cues, that is they see something, some visuals, or they read something erotic, still they are not having any kind of erosion. And then sensation during the activity, when the male partner, when their partner tries to initiate the sex, at that time they are not having any kind of arousal or interest, whether it is genital touch or non-genital touch. And it can be both type situationals, that is in a particular situation with a particular partner, or it might be generalized. So there are hypoactive desire and initiation desire, absent or decreased initiation of sexual activity. And to make any diagnosis of sexual disorder, it has to be present 75 to 100% of times, and for a duration of 6 months at least. and they should be significantly distressful for the patient. It's not that the observation only will lead to this thing. It should causing distress to the patient, then only, and it has to be present for 6 months, then only we diagnose that this is a female sexual disorder which we are encountering in this particular patient.
Very, very well taken. So we have this explicit model, ma'am. This explicit model of evaluation of female sexual intimation and their arousal disorder that says that P for is permission, L is limited information, S is for specific suggestions, and T is for intensive therapy. So this is a very, very extensive model for which recognizes underlying conditions contributing the reduced desire, where we have major relationship or physical issues, maybe soliciting more detailed information from patients about their experience of low desire, maybe onset, duration, behavioral adaptation and avoidance, and level of distress. A close evaluation of these patients, they reveal that there are certain important medical history, including reproductive history that was absurd, maybe certain comorbid conditions and endocrine and neurological, cardiovascular, as well as psychiatric disorders that can be there, and use of prescription and over-the-counter medications that were the cause of such arousal disorders. So, anybody, Dr. Manju Prabhakar, ma'am, can you highlight this on what are the defining criteria of the types of female orgasmic disorders? This is something that we usually do not talk about in our OPDs, but can you show the slide, Dr. Madan? Now, what are the defining criteria of the types of female orgasmic disorders?
Yeah, thank you, Dr. Prerna, for asking me this question. Am I audible clearly?
Yeah.
Oh, okay. Dr. Varida, are you taking this question or I have to take this question?
I can take.
Because she asked me to take
the-
that. But if you are prepared, then you can take that.
I can take
Okay.
I can take this question also.
Okay.
So diagnosis of orgasmic disorder is based on DSM-5 criteria. Delayed. There are many delayed, infrequent, or absent orgasm altogether, or markedly decreased intensity of orgasm might be there on almost all occasion of the sexual activity, and distress or interpersonal problems due to orgasmic disorder can be present, and no other disorder or substance that exclusively account for the orgasmic dysfunction should
Can
be
you please
there.
share the slides?
And the symptoms must have been present
Dr.
for more
Madan,
than
please move the
6
slide.
months. So this is the DSM-5 criteria to diagnose the orgasmic disorder. And there are many types of orgasmic disorders, which can be primary, where she didn't have any orgasm ever, and secondary anorgasmia, that she used to have orgasm normally, but later on she is having difficulty in reaching the climax. Situational can be in other circumstances, like in oral or masturbation, or certain partner she is reaching to the climax very easily, but with this particular partner she is unable to have. And generalized an orgasm, no orgasm in any situation or partner. And there is one more thing, there is sometimes there is muted orgasm, that she is having she is having this release of tension, but it is not that she is going into the slumber of the resolution phase. So that is called a muted orgasm. So these are the type of orgasms an orgasmia she can be having.
Yes, ma'am. The motive of bringing this particular question into our panel discussion was that when we are evaluating a female, whenever she is coming for dyspareunia, whether she is coming for some sort of vaginismus, or some sort of coital disorder, we need to actually put it into writing, into documentation as to what type of orgasmic disorder does she actually have. So this is what we are actually wanting to highlight here, that we need to practice it in our day-to-day clinical scenarios, that we need to classify these particular patients and then take them as per se for the management proper. So Manju ma'am, would you like to add on to the previous, because you're wanting to say something there?
It was very clearly depicted in all the slides and very nicely explained by Dr. Varida Sheth. And I just want to add one thing, that in our
social scenario, females are mostly, they are hiding that their sexual pleasure. And this orgasmic disorders, they are just hiding that. And they are not very open to talk about that. But to explain them and to evaluate them, we have to ask for the leading questions from these females so that we can advise them and we can treat them properly. So for that
Very true.
purpose, this orgasmic problems have to be very well defined, and we have to categorize in which particular category this particular female is in, so that we can
Very
give
well.
them good treatment for that.
Very well highlighted and very true practical point, ma'am. Because we are still living in an era where when a couple comes into our clinic, the usual question is that the female is not talking about her orgasm and the male
Yeah.
is talking about his erectile dysfunction. So there's something which is very, very painful, and still today's date with so much of social media hogging around, we have to be a lot more cautious about the way we act. So Poonam ma'am, would you like to give your expert input on this? And
Yeah, actually, the orgasmic disorder, am I audible? Yes. The
yes,
orgasmic disorder is something which is in their, youth. Even then, the female, the foreplay matters. The fact is that female takes more time for the arousal. And in married couples, this becomes a routine. And the dopamine factor that, yes, once whatever is attained with a regular gush of dopamine, the next time more and more trigger is needed for that rush of dopamine. So a tolerance sort of thing also develops. So what we discussed, that in aging couple there is the privacy, the social factors are also there, because see, the aging couples are thought to be the social more for the family. The husband is for taking the kids to the school, for sabzi lana and other things. So wo jo privacy part is missing, that is also responsible. And all that GSM factor which takes more time for the arousal part, that is the physical factors. And emotional aspects, they also come. So all these, along with all these things, orgasm is not there. So the final thing, the pleasure is not there, and then there comes the avoidance of the partner, because the female or the male, they both think that whatever is going to happen, we are not going to get the pleasure. So the fact
yes,
is
ma'am.
that, yeah, the syndromic, the holistic approach is needed to treat such patients
Yes,
from
ma'am.
every
Very, very,
aspect.
very true.
Yes.
Holistic approach and privacy. These are
Yeah.
two key words that you have mentioned. And we can take this question with Dr. Kalpana Dikshit, if you're there, ma'am. What are the causes of painful sexual act? Another very important thing that we commonly face in our clinics. Kalpana, ma'am, if you're there. Dr. Neha, ma'am, if you're there.
Dr. Sanchita is there. Dr. Sanchita.
Yes. Dr. Deepali, ma'am, is there. Deepali Verma, ma'am. Anyone can take
Okay,
this, Dr.
so
Yes.
shall I answer this?
Yes, yes,
Yes,
yes,
please.
please.
Yeah. So we have मैं करूँगी हाँ. So see, we all know that painful intercourse, the most common is the tightness, which may be pain at the entry point, or it may be a deep dyspareunia. So most common for this is either a vaginismus where the muscles are tight, or it may be some vaginal septum or imperforate hymen, and a lot of some psychological aspects also, where she has a past history of some unpleasant event. Sometimes even vaginal infections also lead to painful intercourse. And yes, of course, emotional aspects and psychological due to past history is there. So when we talk about pain during intercourse, vaginismus is something which we really need to address. It is then there are grades of it. So you need to understand, and sometimes it is just a physical thing. Sometimes it is associated with psychological aspect of the previous history also. So we know that what vaginismus is. It's a condition which leads to painful intercourse, and involuntarily patients tighten their cells, and they don't even, at times when it is grade 4 and all, they don't even allow the touch also in that area. The moment the penis hits that, and the yes, of course, this grade, then grade 5 is where they start sweating and they start trembling. So whenever you come across such patients, you have to be really patient with them. You need to make them comfortable. If on the first visit they are not ready for examination to grade it, you can always tell them, okay, this is what we are going to do, and you can come back again, and then we will examine you in detail. Just make them comfortable. And if she allows you to examine, and the mildest form is grade 1, when there is a spasm, when you examine and it is patient is keeping it very very tight, and you can do a little penetration, but then the examination is difficult, that is grade 2. When the patient avoids a complete examination, she elevates and closes her thighs, that is grade 3. Grade 4 is, of course, sometimes the gynecologists even get the kick of the patient also while doing examination in grade 4. And grade 5, when there is a vasomotor component to it, they start sweating, shivering, and it becomes very difficult. So these are the grades of vaginismus for painful intercourse.
Thank you, Dr. Sanchita. Thank you. So, Dr. Madan, would you like to take it forward?
Yes, rightly highlighted by Dr. Sanchita. As we are dealing with the female sexual dysfunctions, whenever the case comes in our OPD, first question arises how to deal with, what to do next. Then, after taking the history, the main portion remains to evaluate that case regarding the management. Then I would like to hear from Dr. Neha, ma'am. How will you evaluate such a case of female sexual dysfunction?
Good evening, everyone, and I would like to thank you for making me a part of this panel discussion. When such a patient comes to us who's having this form of sexual dysfunction, so it is very important to elicit the history of the patient, to know about the sexual patterns, the detailed history of difficulties, what difficulty she's facing, whether she's having a single partner or multiple partners, and any high risk behavior if she's having. Apart from this, the medical history of any medical diseases, any chronic psychiatric illnesses, if she has undergone any surgery, if she is taking any antidepressants, anti-anxiety medicines, and we need to take a complete gynecological and obstetrical history of such a patient. Then, apart from history, then we need to examine this patient if she is facing any problem related to her vulva, vagina. We need to do a proper per speculum, per vaginal examination in such patients. And if necessary, any tests like ultrasound, if needed, CT scan, all these tests need to be done if we have to rule out certain congenital problems in the vagina, like a septa or any other problems in the uterus, and in that case we might need to do an MRI also. Then further testing regarding the hormonal profile of the patient, we need to do hormones and serological testing of the patient. Then there is this checklist which we can give to a patient, and we can tell the patient to answer, and she can know what problem she's facing, whether she's satisfied with the sexual function or not. Then how long has it been that she has been dissatisfied with the sexual function. Then these are list of questions which she needs to ask herself and answer, and according to this checklist we can come to the conclusion that what actually problem the patient is facing.
Yes, Neha ma'am, you rightly pointed out there is the symptom checklist for women, and that will definitely help us to reach the diagnosis. Yeah. Then discuss something about the menopause. What happens in menopause and how the menopause affects the sexual life of an individual and the both the partners. Yes, we would like to hear from Dr. Methi, ma'am. How the menopause will affect the sex life?
Good evening, everybody, and thank you for inviting me as a panelist. Now, during menopause, there is a lowered estrogen level, and that makes the vaginal tissue thin and dry. Now,
Yeah.
this is called vaginal atrophy, as rightly taught to us by Dr. Sanchita, and that atrophy makes the intercourse uncomfortable and painful. Now, the lower hormones may also lower the sex drive, and because of the lower sex drive, it takes us longer to get aroused and to complete the intercourse. Now, the other factors could be night sweats, which happen due to the menopause, that makes a disturbed sleep and then causes exhaustion and tiredness. Certain emotional changes like stress, irritability, mood swings also affect the sexual intercourse. A feeling of body shaming or body disfigurement is also associated with a uh, painful intercourse. All these factors, or just being less interested as a person gets older, although not a medical condition, but may require some treatment. And this causes stress and problems in the patient. It should be really discussed with the treating doctor.
Yes, ma'am. All is happening due to the lower estrogen levels, and these lower estrogen levels affect many systems.
We should
And
not forget other medical conditions which might be there, like hypertension or diabetes, due to which she might be having all other health conditions which are affecting her psyche, that whether I should indulge in this thing or not. This is very
Yes.
important thing.
yes, again, the age is also at the age of around 45 or 50, the female partner may think that why there is need of sex. Already children are there, they are grown up. We should not have sex, or menopause is the end of sex life. That is also a myth. And that is and at the same time, they have to maintain their emotional connections also. Okay. So the next part comes, what measures you can advise to improve the sexual life? We have seen the pathophysiology and everything. Then what we can do or we can advise? Yes, is there Dr. Sudeep?
Yes, Dr. Madan, I'm very much there.
Yeah. Please take up this question. What you can
Uh,
do? Yeah.
what we can do to improve sexual health. So,
Okay.
it can always be done by compassion and tender love and care. So the couple should, first of all, I think they should open about sexual problems. Like couple should always discuss without hesitation about what they want and how they want to be done. Like the Poonam ma'am rightly said that pleasure gets reduced in a mid-sexual life. Pleasure gets reduced. So they should discuss with each other how to improve this pleasure. And also, while we were discussing about the pregnancy and sex, the speaker rightly said that sexual act is not everything. Like cuddling and being together with each other also matters. So the things should be slowly started from this. And in order to be fit for this, one can stay physically active, because if both of them are physically active, it improves their energy levels, it improves, elevates their mood, and also it helps to secrete happy hormones like dopamine and all. Uh, Also, the couple should quit smoking. Like in females, if they smoke, there is decreased blood flow to vagina, and also estrogen gets all the more reduced. So one should quit smoking, and one should also avoid taking drugs and alcohol, because it delays the arousal response. And the couple should have sex more often, because it habituates the vagina having sex. And also foreplay is a must for arousal. One should not like jump into the sexual act. And so foreplay is very important. And the mid sexual life patients should practice pelvic floor muscle exercises regularly, because it improves the blood flow to the vagina, and also it helps in doing the sexual act. And also the patients should avoid using irritants, perfumes, soaps in the vaginal area, and they should never do self medication. And like Dr. Sanchita very well said, that if there is problem of vulvovaginal atrophy, then it should be addressed by using either lubricants or estrogen creams. And we all are practicing laser. So I personally use erbium laser for GSM, and it works very well. So I think this is all what can be done to improve the sexual life of the people in mid
Yes,
age
yes,
group.
Dr. Sudeep, as you are the pioneer in the aesthetic practice in Moradabad, you might be dealing with some patients or sexual complaints, perimenopausal patients. Which common complaints do you face? Which are the common complaints of females in the perimenopausal in your practice?
Dr. Madan, usually people come with the problems of dryness of vagina and burning sensation in vagina. And also the dyspareunia is also very common in this age group. Like earlier they used to enjoy sex, but after having menopause, when the menopause stays for like 4 to 5 years, then they start like disliking the sexual activity. And this is all because of that dryness, that lack of lubrication. And also some of the patients, they even complain of getting few vaginal tears and all. So mainly they come with this only.
Okay, thank you.
Husbands, they come with the problem that now the wife is not responding to their sexual urges, and she's losing desire to have sex. Husbands will always come with problems like that.
Yeah, that is the common scenario, and that is why the role of counseling is there. Couple counseling, they need couple counseling proper. Thank you.
Definitely.
Yes.
We can have one take home message from each of our panelists, and then we can wind up, I suppose. So
Yes.
maybe we can start with Dr. Mithi. One take home message for this. Yes, like understanding your body and what makes a healthy sexual response. We need to be physically active. A pelvic floor control exercise are definitely a must. Healthy habits and healthy diet with make time for leisure and relaxation. Accepting changes that occur and communicating with our partners openly will improve our intimacy definitely. With having more time for sexual act, and as well as therapy and counseling can help us whenever required with managing stress and anxiety at work. So, Dr. Mithi, your take home message for our panel?
I think as clinicians, we should be more patient in understanding the patient's complaint and giving the patient more time before we, switch. Earlier, as a gynecologist myself, I was mostly into antifungal and antibiotics. But yes, reading about this topic has changed my practice also, and I am able to handle the patients better now.
Very nice. Thank you. Dr. Deepali, ma'am? Poonam, ma'am? Yes, wanting to say something?
Yeah, yes, dear. So in midlife, the crisis is we all discussed everything. The fact is, the take home message is that sex is not always the penetrative one. To sit together, to cuddle each other, साथ बैठ के मटर छीलना, सब्जी बनाना, खाना बनाना is also a part of sexual life. So we have to encourage them to spend time together, much more time together. Yes.
Very true. Very true.
Please, sir.
Yes, Shalini, ma'am.
Yeah, Dr. Poonam has very rightly said that spending time with each other and quality time with each other, couple can go on holidays also to get more privacy. I think that is second or third or fourth honeymoon also is very essential. Maintain a healthy companionship with your partner.
Yeah.
Neha, ma'am. Sudeep ma'am.
Any such patient comes to us, it is very important for us to reassure the patient, make the patient understand about the normal physiological processes that are going on in her body, and then to give her advice after proper assessment of her emotional and her physical problems, and then guide her accordingly.
Thank you. Thank you for your valuable input. Sudeep ma'am, Kalpana ma'am.
I think we should always be ready to help them out with clear cut solutions to their problem. And secondly, we should always encourage the couple that they are aging. So they should start accepting their body and they should accept their bodily needs also. So it is, as rightly said by Poonam ma'am, that it is not always sexual act. They should cuddle with each other, they should sit together, they should sleep together, and they should accept their body as it is.
According
Kalpana
to,
ma'am.
I would
Farija
like
ma'am.
to say that most important thing is communication between them. Communication between the couple about their expectation from each other. What happens in a family, usually they don't communicate what things make me happy, what thing makes you happy. Most important thing, and as we say in the sensate focus therapy, when we teach them also, it is that they have to communicate about their needs, about their pleasures, and about their requirement from the partner. That is the most important thing. If they can communicate with each other openly about their needs and about their pleasures, that what makes them happy, both during intimacy and off intimacy, because when they communicate with each other their expectations of intimacy, then only they are psychologically satisfied. And when their psyche is satisfied with each other, then only their togetherness, then only their intimacy may be fruitful. That's the most important thing, that they should not stop communicating with each other, because as the time grows, the as the females are taught to subdue themselves always, and as they age they say, okay, whatever husband needs, I'll do it for. And they usually fake orgasm all through their life, and they don't openly talk to their husband what makes them happy. So that is most important thing, probably communication between the couple about their things.
So
Manju ma'am would
nowadays,
like to.
a lot of females have started coming with this thing that, we don't enjoy it. We don't
Yeah.
feel the orgasm. So a
Yeah.
lot of young women, and even at perimenopause and postmenopause also, they start coming. So the best thing is communication, as correctly just now. And one should understand what everyone has got different orgasmic, some foreplay is important, and you need to be more involved in the act. It should not be a very mechanical thing. You have to be totally involved. So what happens, the female is busy with household work, with a lot of stress, मॉर्निंग स्कूल भेजना है बच्चे को, टिफिन तैयार करना है. So all these things are playing at the back of their mind. So we should, always explain it to them. So this is not just a physical contact, this is an emotional contact also, and you need to give time to this relationship. And it is not only for the husband to get the pleasure, it is for you, not a physical pleasure. It is a bond between the two of you which will grow with this. So it is a reset button, which you need to refresh button of your life,
Yeah.
which you need to keep on having.
Very, very good.
Yeah,
Very
very true.
Very
Yes, yes. Very rightly
Manju
said.
ma'am.
Yeah.
Yes.
As we have all talked about all these sexual problems and psychosexual crisis in midlife, we all know that in perimenopausal and immediate postmenopausal period, there are so much going on in the body as well as on hormonal level in the uh, body of the female. And all this makes her so vulnerable psychologically. And she's, most of the time, she's very stressed out, and she's crying without any reason. And she's emotionally upset. And at that time, she feel a emotional disconnect. So, and in those cases, we should always have a very good counseling of both husband and wife so that they communicate to each other, they give support to each other, and with that only they can have a good sexual life also later on in the postmenopausal or perimenopausal period. So, for that purpose, it is very, very important that female accept her body, and she don't have to suppress her desires have to be fulfilled, because at that time, after the age of 50 or 60 years, when her all liabilities of the family have been already completed, then she can start enjoying for herself. So this is the time when most connect is required from the both partners. So we have to counsel them and we have to give them support whenever they come with all these type of sexual desires or arousal problems in our clinics. So for
Thank you.
me, the counseling is very important part for these females then.
So we have heard it all from all our esteemed panelists. Anybody wants to add on something? Yes. So, from privacy to taking out time to counseling to having a thorough checkups. So, these are everything that we could have included, and very esteemed panelists have done justice, and our expert has given her insightful, delightful, and very, very elaborate purviews on a very important subject. So, with this, we come to an end of this panel, and we thank all our experts and panelists for such a wonderful, wonderful time with you all. And whether this
Thank
was
you, Dr.
something.
Prerna and Dr. Madan. It was
Uh,
very, very nice webinar. I
Thank you,
attended
Dr.
today.
Prerna, Dr.
Yeah.
Madan.
Thank
It was
you.
very
Thank you.
nice. And we
Thank
hope to
you.
have such good webinars in
Thank
Yeah.
you,
some
ma'am.
time also.
Wonderful
And
discussion.
UP
And wishing you
UP had
both great success.
Thank
Yeah.
you,
All the
Dr.
And
best,
we
Prerna.
wish
Dr.
you
Prerna,
Thank
Dr.
you.
Madan.
success for your
Best wishes to both of you.
Thank
best
you.
Thank you.
wishes to
Thank you
both
all.
of you for your upcoming elections, Dr.
Thank you,
Kamble and
ma'am.
Dr. Prerna.
We
Thank
enjoyed
you
your
so
great
much.
inputs. We enjoyed your great
And
inputs, and it was a wonderful discussion. And Dr. Sanchita, it was a wonderful talk by you.
Thank you.
Exactly.
Yes,
Yeah.
very nice. The
Thank you so much.
best point was that we should not make them shuttle between the dermat and the urologist and all.
yes,
We can
Yes.
take
Yes,
full charge of our patients
absolutely.
ourselves. We should not send them here and there. That's the best thing I liked
Yeah.
in your
yes.
presentation.
Thank you.
Very practically put out points by everybody,
Yeah.
and it's customary to extend my vote of gratitude. And so I thank each and everyone who has joined in today, right from our chief guest, our guest of honor, our tech support, our panelists, our experts, our speakers, our chairpersons, my co-moderator, Dr. Madan Kamble, Dr. Apurva Datta, and everyone who has joined in, every delegate who has been keen on listening till to the end. And thank you everyone for making this evening a quite success. Thank you and have a pleasant evening.
Thank you,
Bye-bye.
Corona Remedies, for
Thank
the
you. Thank
good
you.
support.
And
Thank you.
very
Thank you,
well
everyone.
moderated by you both, Prerna as
Yeah.
well as Madan. Kudos.
Thank you, Puna
Thank
ma'am.
Yes.
Thank you. Thank you, Corona. Thank you, Harshvardhan.
Thank you so much, sir. Thank you,
Yes.
Madan.
Thank
Thank
you.
you.
Thank you,
Thank you
Prerna.
all.
And thank you
Yeah.
all
Bye,
our dear
everyone.
esteemed faculty.
Bye. Good night.
Bye. Good night.
Good night, sir.
Good night.